Today, I will be discussing the outpatient evaluation of the febrile infant 90 days of age or younger. Basically, this PowerPoint slide is for your reference. If you're not sure about any of the abbreviations that I use, you can always go back to this slide. A pediatric fever for infants 90 days of age or younger. We consider that a rectal temperature of 38 degrees Celsius or 100.4 degrees Fahrenheit. The two main etiologies for a febrile fever that I will be discussing today is a viral infection and invasive bacterial infections. Viral infections are the most common cause of fever in infants. Neonates with viral infection remain at high risk for invasive bacterial infections. Infants 29 to 90 days of age have lower risk of invasive bacterial infections, but still significant risk for urinary tract infection. Serious viral illness in febrile infants include HSV, varicella-zoster virus, enterovirus, influenza virus, some adenoviruses, and RSV. Neonates and young infants are more likely than older infants to experience morbidity from a viral infection due to decreased responsiveness of T cell-mediated immunity. Serious bacterial infections, we consider these invasive infections such as bacteremia, bacterial meningitis, bacterial pneumonia, skin and soft tissue infections, osteomyelitis, bacterial gastroenteritis, septic arthritis, or a urinary tract infection, which is the most common. Some risk factors that you should be looking for are age, especially younger than 28 days of age, ill appearance. Other causes for ill appearance include congenital heart disease, congenital adrenal hyperplasia, inborn errors of metabolism, malrotation with volvulus, so just keep an eye out for those things too. Change in behavior such as decreased feeding, poor tone, irritability, lethargy, or increased sleeping, a rectal temperature greater than or equal to 40 degrees Celsius or 104 degrees Fahrenheit. Hyperpyrexia is rare, younger than 3 months of age, but highly associated with invasive bacterial infection when it occurs. Another risk factor is a rectal temperature greater than or equal to 38.6 degrees Celsius, 101.5 degrees Fahrenheit. Risk for bacterial etiology appears to increase with increasing fever. Many experts use this number as an additional risk factor that requires a full sepsis evaluation. Unimmunized, those who have not received the first dose of pneumococcal and Hib vaccine. Immunization with conjugate pneumococcal vaccines decreases rates of bacteremia and appears to have direct and herd immunity benefits. There was an observational cohort study of 30 years of age and younger, which included 50 immunized and 67 unimmunized infants, 0 to 90 days of age. And they found that bacterial infection was higher among the unimmunized compared to the immunized, 7% versus 0%, and no cases of pneumococcal and bacteremia in infants who had received at least one dose of the heptavalent pneumococcal vaccine or the unimmunized neonates younger than 28 days of age. Additional risk factors, prematurity, considered a gestational age less than 37 weeks. Rate of sepsis is 10 to 12 times that of term infants. This is due to immature immune protective mechanisms. But excluding any comorbidities, once the age is corrected, it has a similar incidence to the term match controls. For example, an 8-week-old born at 34 weeks gestation, considered 6 weeks early, has a similar risk for a serious bacterial infection as a 2-week-old term infant. Other risk factors, comorbidities or chronic illness, infants with perinatal course complicated by surgery, infection, congenital or chromosomal abnormality, medically fragile patients who are dependent upon technology or specific therapies such as the home ventilator, home oxygen, or TPN, those who have received antibiotics within the prior 3 to 7 days. This is because the long half-life of antibiotics in young infants, administration up to 7 days prior may mask signs and symptoms of an invasive bacterial infection. Another risk factor is the risk of maternally transmitted infections, such as maternal fever, prolonged rupture of membranes, maternal culture positive for GBS, maternal history of genital herpes. Social barriers to follow-up that might hinder follow-up is limited skills by caregiver to assess severity of diseases or educational barriers, limited access to medical home for questions and or follow-up, lack of transportation, or language limitations. So bacterial pathogens to consider are E. coli, which can be seen in bacteremia, bacterial meningitis, and a urinary tract infection. Group B strep, which can be seen in bacteremia and meningitis. Listeria monocytogenes, which is primarily in neonates less than 28 days of age and premature infants. S. aureus, which can be seen in skin and soft tissue infections and osteomyelitis. Streptococcus pneumoniae. Salmonella species, especially suspect this with fever, diarrhea, or blood in the stool, and it can have associated bacteremia or meningitis. The rest of these you can read on your own time. Evaluation. The goal of thorough evaluation is to identify infants at high risk for invasive bacterial infection or serious viral infection requiring empiric antimicrobial therapy and hospitalization. A full sepsis evaluation consists of a CBC with differential, blood or serum glucose to compare with CSF glucose, inflammatory markers. These include PCT and CRP. These are rapidly available within 60 minutes. Blood culture, urinalysis, urine culture. Make sure that you send a urine culture regardless of UA findings because a negative UA alone does not exclude a UTI. Chest radiograph, stool culture in infants with diarrhea or stool containing blood or mucus, and a CSF studies. So you can read the CSF studies here since this is not something that we usually, well, it's not something that we can really do at our practice. I'm not going to go into too much detail about it. And then if signs of septic shock, prothrombin time, APTT, and INR. Fibrinogen and D-dimer, serum lactate, serum total bilirubin, and alanine aminotransferase, and ionized calcium. Those that may require full sepsis evaluation are ill-appearing infants, neonates younger than 28 days of age, including neonates with a recognizable or testable viral infection, such as bronchiolitis, croup, influenza, or enterovirus, or focal bacterial infection. Those with findings suggestive of HSV infection, especially with maternal risk factors for vertical transmission. Infants 29 to 60 days of age with any one of the following risk factors for invasive bacterial infection. Rectal temperature greater than or equal to 38.6 degrees Celsius, congenital or chromosomal defects, especially those associated with increased risk of infection, technology dependent, and those who have antibiotic therapy in the past 3 to 7 days. Then also consider those with infants 29 to 90 days of age with a focal infection and abnormal white blood count, absolute band count, inflammatory markers, or urinalysis. Traditionally, a full sepsis evaluation was suggested for all well-appearing febrile young infants with focal infections, but it is now determined on the extent of focal infections, results of preliminary blood and urine studies on a case-by-case basis. All right, so now we're going to discuss the well-appearing febrile infant 29 to 60 days of age. This is a infant with no focal bacterial infections, clinical findings of HSV infection, or other risk factors for invasive bacterial infection, and a rectal temperature less than 38.6 degrees Celsius, which is 101.5 degrees Fahrenheit. With these infants, consider a CBC with differential, PCT, or CRP if readily available. Blood culture, UA, urine culture, chest x-ray in patients with signs of respiratory illness, such as a cough, tachypnea, or abnormal breath sound. If any of the following are abnormal, the patient is to undergo lumbar puncture with collection of CSF studies and empiric antibiotic therapy, as you can read here. If all the labs are normal, consider doing no antibiotics and close observation as an outpatient, and make the patient an outpatient, or intramuscular ceftriaxone pending culture studies, culture results. Well-appearing febrile infant, 29 to 90 days of age with a focal infection. As you can see, this is very similar to the previous slide, except for that the patients, other than those with cellulitis or abscess, have a urinalysis and UA. So if you have a patient who you think has cellulitis or an abscess, you don't necessarily have to do those. And again, lumbar puncture with CSF studies for any of the following abnormalities as listed. Because patients will undergo empiric treatments with antibiotics, some experts suggest lumbar puncture in all febrile infants 29 to 90 days of age with a focal infection to minimize risk of missing bacterial meningitis, especially those with focal infections likely caused by group B strep, so septic arthritis or osteomyelitis. Evidence is lacking regarding risk of bacteremia and meningitis in well-appearing febrile infants with focal infections. So here we have a well-appearing febrile infant, 29 to 90 days of age, with a recognizable or testable viral infection. Again, this is kind of the same list that you've been seeing with these other criteria, but at this age, you can just do a urinalysis, urine culture, and a chest x-ray in patients with signs of respiratory illness. This is an algorithm for 29 to 60 days of age. And this is also on the email that I sent you if you'd like a better picture. Okay. A well-appearing infant, well-appearing febrile infant, 61 to 90 days of age with a temperature less than or equal to 38.6 degrees Celsius. You can do a urinalysis and urine culture. Some experts recommend CBC and blood culture, especially infants who have not received first immunizations with conjugated vaccines. It's a varied approach to infants 42 to 90 days of age who have a fever within 48 hours of immunization, and I'm going to discuss that a little bit more later. This is the 61 to 90 days of age with no focal bacterial infections algorithm, which I've also sent to your email. So some things to consider in the history to ask for is true rectal temperature fever, findings indicative of higher risk for invasive bacterial infections as discussed before, associated symptoms, exposures to sick contacts, and social barriers to outpatient management. In regards to a physical exam, make sure to identify and stabilize infants in respiratory or circulatory compromise. Some such things to look for are apnea, respiratory distress, signs of shock, such as tachycardia with poor perfusion, irritability, poor tone, lethargy. Also look for sources of infection. With bacterial infection, acute suppurative otitis media, bulging or inflamed tympanic membrane. With pneumonia, look for tachypnea, respiratory distress, grunting, flaring, chest retractions. Decreased oxygen saturation, cough, crackles, or decreased breath sounds on auscultation. For omphalitis, you can look for purulent drainage from the umbilical stump, circumferential erythema with tenderness, and/or induration around the umbilicus. Bacterial arthritis, swollen, painful, warm, red joints. Osteomyelitis, maybe decreased use of a limb with localized swelling or erythema. Cutaneous cellulitis or abscess, look for redness, induration, warmth, and drainage from the skin lesion. With meningitis, you can be looking for irritability, lethargy, bulging fontanelle, or knuckle rigidity. But keep in mind that it is a rare finding in young infants. With serious viral infections such as HSV, looking for mucocutaneous vesicles, seizures, especially with facial automatisms such as lip smacking or lip pursing, eye deviation or unresponsiveness, focal neurological focal neurologic signs, respiratory distress, apnea or progressive pneumonitis, conjunctivitis, such as excessive tearing or painful eye symptoms, sepsis-like illness, so fever, hypothermia, irritability, lethargy, respiratory distress, apnea, abdominal distension, hepatomegaly, or ascites. With a bronchiolitis, you can look for tachypnea, copious nasal discharge, cough, rales, wheezing, or apnea. So I then kind of split these up into evaluation by findings. With bronchiolitis and influenza, rapid testing is good, but the results do not determine need for antibiotics or anti-influenza drugs in an ill-appearing infant. Less than 28 days of age requires a full evaluation. Greater than 28 days of age, consider also doing a UA and urine culture. Some experts would obtain a CBC and blood culture in infants not well appearing or have not received conjugate vaccines. And evidence suggests risk of bacteremia and meningitis is also lower in infants with a positive rapid influenza testing. Those who were positive for influenza who had a bacterial infection, it was a urinary tract infection um, for all of those. HSV infection, you can do surface viral cultures of the um, mouth, nasopharynx, and rectum, swab or scrapings from skin vesicles, blood PCR, and serum ALT, AST for HSV-associated hepatitis. But keep in mind that can also be elevated and disseminated enteroviral infection or in septic shock. For acute otitis media, in less than or equal to 60 days of age, evaluate and manage like febrile infants without acute otitis media. A greater than 60 days of age, it's debatable. You have the choice of no further studies or a UA. That might be most appropriate for infants approaching 90 days of age with a rectal temperature of less than 38.6 degrees Celsius. You could do a urine culture with or without blood cultures prior to treatment. It's most appropriate for infants closer to 60 days of age with a rectal temperature greater than or equal to 38.6 degrees Celsius. Presence of acute otitis media did not predict a higher risk of a serious bacterial infection, so they recommend not routinely performing CSF studies. Okay, and then on to urinary tract infections. Most infants greater than 2 months of age with a UTI can be safely managed as outpatients as long as close follow-up is possible. Usual indications to hospitalize and/or parenteral therapy include age less than 2 months of age, clinical urosepsis such as toxic appearance, hypotension or poor capillary refill, immunocompromised patients, vomiting or inability to tolerate oral medication, lack of adequate outpatient follow-up, or failure to respond to outpatient therapy. Okay, urinary tract infection continued. Those 29 to 60 days of age, well appearing with abnormal urinalysis, abnormal blood studies, risk factors for invasive bacterial infection, or a temperature greater than or equal to 38.6 degrees Celsius, should have CSF tests, empiric parenteral antibiotics in hospital pending culture results. Dosing should be sufficient to treat meningitis until initial results of CSF testing are available. I'm not going into too much detail about the CSF studies again. 29 to 60 days of age, well appearing, abnormal urinalysis, normal blood studies, no risk factors for bacterial infection, and a temperature of less than 38.6 degrees Celsius, can receive oral antibiotics and close follow-up as outpatient. Greater than 60 days of age, without vomiting, can be treated with orally administered antibiotics. Again, keep close contact for the first 2 to 3 days. Infants 29 to 60 days of age with positive urine culture who are afebrile and well appearing less than 24 hours after IM ceftriaxone have options of a second dose of ceftriaxone at 24 hours or initiation of oral antibiotics and continued outpatient follow-up. All indicate imaging for further evaluation, such as renal or bladder ultrasound, VCUG, or renal scintigraphy. All right, so back to those recently immunized options. Greater than 60 days of age with a rectal temperature of less than 38.6 degrees Celsius or 101.5 degrees Fahrenheit. Less than 24 hours after immunization, consider no testing with close follow-up to ensure that the fever resolves within 48 hours of vaccine administration. Greater than 60 days of age and greater than 24 to 48 hours after immunization, consider doing urine testing. 42 to 60 days of age, less than 38.6 degrees Celsius, consider urine and blood testing with CSF studies if inflammatory markers are abnormal. in less than 60 days of age with a rectal temperature greater than 38.6 degrees Celsius, or, or other risk factors for invasive bacterial infection, consider a full sepsis workup. And this last page here are just the links that I used. I used mostly up-to-date articles to make up this lecture. If you have any questions, feel free to email me. Thank you for your time.